All right, welcome. So I'm going to do a live stream showing a case from this past month where I removed a perfectly good intraocular lens. This is, as you can see here, I'll show this video, this entire surgical video of this IOL exchange. This is a patient who had had a Clareon IOL from Alcon, and although her vision was 20/20 uncorrected, she had a significant improvement in her vision. She was not happy because of negative dysphotopsias or unwanted characteristics of her vision. She felt like she had something blocking her vision to the side, almost like which extended both above and below her eye, and it was quite significant for her. For her second eye, this was her first eye. She was happy with her vision. The vision improved, but she didn't like the fact that she had this negative dysphotopsia or this aberration in her vision. So for her second eye, we actually ended up placing a Bausch& Lomb LI61AO IOL, which is a which is a three-piece silicone IOL. And she didn't have those same issues with her second eye. So this is about 3 months after her original cataract surgery. She wanted me to remove this lens and replace it with the silicone three-piece IOL like she had in her other eye. So we can talk about this. This is obviously a discussion you have to have with the patient because this is an eye that sees 20/20 uncorrected. By everything that we measure in the office, this patient is doing really well, but she's still yet unhappy with her vision. So I offered her, and I was amenable to doing this IOL exchange, removing a single piece hydrophobic acrylic IOL for a three-piece silicone IOL. So I'm going to go ahead and just start the video. Bear with me. And I'm going to play this just at regular speed. So she's 3 months out from surgery, and we can see the IOL is in really perfect position. We have good capsular overlap here, 360 degrees of the anterior capsular leaflet over the IOL optic. I've made my paracentesis incision, one of them. For the IOL exchanges, I like to make incisions at, as you see here, at approximately 7 and 10 o'clock. And that gives me access with both my right hand and my left hand. This is likely preservative-free lidocaine, which we're injecting here. And we're using this to achieve anesthesia. This is done under topical anesthetic. So once we do that, the next step is going to be to inject viscoelastic. Here I'm going to use a dispersive viscoelastic viscoat into the anterior chamber. And I want to separate the IOL optic from the anterior capsule, and I want to open up the capsular bag. So we're just going with the regular viscoat cannula here. I'm going over the haptic, and I'm trying to get that bag open. And I can see there the bag is opening up nicely. Now this is only 3 months out, but sometimes even 3 months out it can be difficult to open up that capsular bag. And so I'm using lots of dispersive viscoelastic here. Going to try and free up that IOL, rotate it, and you can already see it's already starting to move. Rotate that IOL out of the capsular bag and into the anterior chamber. So we can see here that both haptics really do appear to be loose, which is fantastic here. That makes this case a whole lot easier. I have had cases in the past where you're not able to free up the haptic, in which case you can then go in and amputate the haptic and leave the haptic really in place. I'll go in here with a Lester hook, and we're rotating the IOL out into the anterior chamber. So once again, this is, if you're just joining, this patient was 3 months out from cataract surgery, got 20/20 uncorrected visual acuity, significant improvement in her vision, and still, however, was having negative dysphotopsias that she felt were really quite disabling. And so we decided to proceed with exchanging the IOL. We're taking out the single piece hydrophobic acrylic and replacing it with a three-piece silicone IOL. So just freeing up that IOL here. And I'm actually going to increase the speed of this video. Let's go a little bit more quickly here. So this is now twice the speed. And now that we got the IOL into the anterior chamber, we're going to have to open up the main incision. So I am, since we're only 3 months out from surgery, oftentimes you can use a Sinskey hook, just open up that incision. And that's what I'm doing here. I'm going with a Sinskey hook. I'm trying to locate the plane of that incision. I'm not going to do this too much. If I'm not able to readily locate it, I'm just going to go ahead and take the Clareon blade and make another incision. But if we're able to open up the previous incision, which we are able to here, I much prefer that. And since I'm going to do a twist technique here, I'm going to enlarge this incision somewhat. This original incision was 2.4 millimeter incision, and we're probably up to about a 3 or maybe even a little bit more at this point in time. And so once we've opened up that incision, we're going to take the first haptic and take that haptic out of the eye. And then going to grab angled Kelman or forceps, and I'm going to reach across the IOL, and I'm injecting viscoelastic here to protect the corneal endothelium. And as I grab the IOL, I actually like to use forceps usually with that have a longer forceps here. As you can see, this forceps really only goes across half the IOL. For some reason, that was a forceps that I had in this tray. And then we use a cyclodialysis spatula here to keep the IOL away from the cornea. And then we pull the IOL out of the anterior chamber. You can see that's pretty atraumatic. You want to avoid brushing or pulling the IOL along the corneal endothelium, because you will have corneal edema the next day if you do that. And so now we got that out. I'm going now with a cohesive viscoelastic. This is ProVisc, and we're going to put in our 3-piece IOL directly into the capsular bag. We've opened up the capsular bag nicely here. It's already all opened up all the way up to the fornix. And this is the inserter for the Bausch & Lomb silicone 3-piece IOL. That lens comes out nicely. And then we place the trailing haptic into the capsular bag. We're going to go in now with IA to remove the viscoelastic from the anterior chamber. We want to make sure we have good capsular overlap with this IOL as well, that it's well centered. I'm going to use a larger sleeve here because we've enlarged the incision. We want to minimize how much water egresses out of the wound, but we still do have some egress out of the wound there. And then we'll just spend a little bit of time removing the viscoelastic. And you can see this patient, things are looking really nice for this patient. Pretty atraumatic intraocular lens exchange. And, that's pretty much the case. We just spent some time removing the viscoelastic. There's some posterior capsular haze there, which I tried to polish. Really didn't have much luck with that. I wasn't going to be too aggressive with that because it's not in the visual axis, number one. Number two, even if it was, I could still do laser capsulotomy later. And number three, I don't want to rupture the posterior capsule in this beautiful case. So then we just hydrate the wounds, make sure things are nice and watertight, that we're happy with the pressure. And that is the IOL exchange for this patient. She actually went on to do very well. When I saw her the first day after surgery, she was 20/20 uncorrected. She was still dilated, but she'd already noticed that her negative dysphotopsia had resolved, was no longer present. And that is the case with these patients. You'll notice initially, you'll notice right away that they have an improvement in their symptom. So in any case, that is a IOL exchange of a perfectly healthy and beautiful IOL before it goes in there, but the patient's not happy. So we've got to address the patient's symptoms and take care of it. Of course, you want to make sure you're comfortable doing the surgery, number one. Number two, let the patient know, obviously the risks, including the risk of capsular rupture, having to place a sulcus IOL or even an AC IOL if there's not even support, although that would be unlikely. But this is a good solution for our patients. It's something that we often will drag our feet to do because we want to make sure, the patient's seeing well, they're seeing 20/20. But if the patient's having a problem, we do need to consider addressing it. Of course, first, do no harm. So I'm trying out this format of live streams. Obviously this is accessible later. Let me know if you guys like this, and I'll post interesting cases as they come along. Thank you all for your attention. Once again, this is Mohammed Al Mala from Central Florida. Thank you.